Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about drugs that affect the kidney. We're going to talk about diuretic agents, and we're also going to talk about how to measure kidney function. And I'm here with Grog, who's our teacher, and we're going to have a conversation about these topics. Hopefully, we can learn a lot of things. Grog, are you ready to kick things off?
Yo, guys, welcome to another dope episode of the Human AI podcast. I'm stoked to be your teacher today, diving into drugs that affect the kidney, diabetes agents, and how we measure kidney function.
Diuretic.
All right, jumping right into diuretics. Love the focus. Diuretics are drugs that increase urine output, affecting the kidneys by altering how they handle water and electrolytes. Commonly used in conditions like hypertension, heart failure, and edema. Let's break it down for you and our podcast listeners.
Yes, and before we go deep dive into diuretics, let's talk a bit more generally about different drugs that affect the kidneys and take it from there. Let's talk a bit about ACE inhibitors too, anti-cancer drugs, and NSAIDs, etc.
Perfect. Let's zoom out and cover drugs that affect the kidneys broadly, including ACE inhibitors, anti-cancer drugs, NSAIDs, and more. Setting the stage for you and our podcast listeners before
You
diving
don't need
deep.
to do the introduction. You can just go straight to the questions I ask you, okay?
Got it. Straight to the point. Drugs that affect the kidneys include ACE inhibitors like lisinopril, which reduce blood pressure by blocking angiotensin II, preserving kidney function in diabetes but risking acute kidney injury if overused. Anti-cancer drugs like cisplatin, which can damage kidney tubules, causing nephrotoxicity, and NSAIDs like ibuprofen, which reduce blood flow to the kidneys by inhibiting prostaglandins, potentially
Why
causing.
are they called NSAIDs?
NSAIDs are called non-steroidal anti-inflammatory drugs because they reduce inflammation, pain, and fever without using steroids, targeting cyclooxygenase (COX) enzymes to block prostaglandin production, which can affect kidney blood flow.
Interesting. Okay, and what about do these drugs lead to acute kidney injuries? Explain to us pre-renal, intrinsic, and post-renal too.
NSAIDs, ACE inhibitors, and anti-cancer drugs can lead to acute kidney injury, AKI, which is a sudden decline in kidney function, categorized into pre-renal, intrinsic, and post-renal types, based on the cause. Pre-renal AKI, caused by reduced blood flow to the kidneys, e.g. NSAIDs, like ibuprofen, reduce prostaglandins needed for kidney perfusion, or ACE inhibitors, like lisinopril, lower blood pressure too much, starving the kidneys of blood, leading to decreased filtration. Intrinsic AKI, direct damage to kidney tissue, e.g. anti-cancer drugs, like cisplatin, are toxic to kidney tubules, causing cell death, or NSAIDs can trigger interstitial nephritis, immune-mediated damage.
So wait a sec. If we could summarize it in a sentence or two, can we summarize pre-renal, post-renal, and intrinsic?
Pre-renal AKI results from reduced blood flow to the kidneys. Intrinsic AKI from direct kidney tissue damage, and post-renal AKI from urine flow obstruction, all potentially triggered by drugs like NSAIDs, ACE inhibitors, or anti-cancer agents. Want to dive deeper into one type?
No, you just repeated what I said. My question was, what is each of these categories in one or two sentences?
Prerenal AKI is kidney dysfunction due to inadequate blood flow, often from drugs like NSAIDs, reducing perfusion, or ACE inhibitors, lowering blood pressure excessively. Intrinsic AKI involves direct kidney tissue damage, like from cisplatins tubular toxicity or NSAID-induced nephritis, while postrenal AKI stems from urine flow blockage, though less commonly drug-related. Ready for diabetes agents or more on AKI?
Okay, and why do these names, pre-renal, intrinsic, post-renal, have these functions? Like, are due to these reasons? Can you explain how their names relate to their structures and functions? Also, if you could talk a bit about antiviral agents, aminoglycosides, and maybe lithium, radio contrast media, and if you could talk when I say briefly, I mean 2-3 sentences, by the way. Briefly.
The names prerenal, intrinsic, and postrenal describe acute kidney injury, AKI, based on where the problem occurs relative to the kidney's structure and function. Plus, I'll briefly cover antiviral agents, aminoglycosides, lithium, and radio contrast media in 2 to 3 sentences each for you and our podcast listeners. Prerenal AKI. Named pre before because the issue is reduced blood flow before it reaches the kidney's filtering units. Glomeruli, like when NSAIDs block prostaglandins that maintain kidney perfusion, or ACE inhibitors drop blood pressure, impairing filtration. The kidneys themselves are structurally fine, but they can't filter properly due to insufficient blood supply. Intrinsic AKI. Called intrinsic because the damage is within the kidney's internal structures, tubules, glomeruli, or interstitium.
What about things as SGLT2 inhibitors, flozins, for lowering high blood glucose in diabetic patients? How do these work? Empagliflozin and dapagliflozin or ADH analogs. Can we talk about those two? 2-3 sentences again.
All right, diving straight into SGLT2 inhibitors, flozins like empagliflozin and dapagliflozin, and ADH analogs, explaining how they work for diabetic patients or kidney function in 2 to 3 sentences each for you and our podcast listeners. SGLT2 inhibitors, flozins. SGLT2 inhibitors like empagliflozin and dapagliflozin lower blood glucose in diabetic patients by blocking sodium glucose cotransporter 2 in the kidneys, preventing glucose reabsorption and increasing urinary glucose excretion. They also reduce kidney stress and protect against diabetic nephropathy by lowering glomerular pressure, but may cause urinary tract infections or dehydration as side effects. Their flozin suffix reflects their chemical structure and role in glucose flux. Empagliflozin, a flozin, inhibits SGLT2 in the proximal tubule, promoting glucose and sodium excretion, which lowers blood sugar and blood pressure in type 2 diabetes while offering kidney protection. It reduces cardiovascular risk in diabetic patients but can lead to hypotension or ketoacidosis in rare cases. The name stems from its development code and flozin class. Dapagliflozin, another SGLT2 inhibitor, works similarly by blocking glucose reabsorption in the kidneys, aiding glycemic control and slowing kidney disease progression in diabetes.
And why vasopressin is an ADH? Explain how vasopressin, explain the etymology of vasopressin. Is something to do with pushing a vessel?
Vasopressin is an ADH, antidiuretic hormone analog, because it mimics ADH's role in regulating water reabsorption in the kidneys, and its etymology reflects its vascular effects. Vasopressin, also called arginine vasopressin, acts on V2 receptors in the kidney's collecting ducts to increase water reabsorption, reducing urine output and concentrating urine, while on V1 receptors, It constricts blood vessels, raising blood pressure. The name vasopressin comes from vaso, Latin for vessel, due to its vasoconstrictive effect, and pressin, from pressure, as it increases blood pressure. Coined in the early 20th century, when its ability to press or constrict vessels was observed. Though its antidiuretic function is key in analogs like
And
desopressin.
why would constricting analogs mean that it's gonna keep urine inside us? Constricting vessels, sorry. Yeah.
Constricting vessels and keeping urine inside seem unrelated, but vasopressin's dual roles explain it. While it constricts blood vessels via V1 receptors, raising blood pressure, as an ADH analog, it acts on V2 receptors in the kidney's collecting ducts to increase aquaporin channels, allowing more water to be reabsorbed from urine back into the blood, thus reducing urine output.
Okay.
This
So let's talk a bit about diuretic agents, since we've covered a bit of an introduction on other drugs. And yeah, we'll go from there.
All right, let's dive into diuretic agents, building on our chat about kidney-affecting drugs for you and our podcast listeners. Diuretics increase urine output by targeting different parts of the nephron, the kidney's filtering unit, altering water and electrolyte reabsorption to treat conditions like hypertension, heart failure, or edema. Here are the main types in 2 to 3 sentences each. Loop diuretics, e.g. furosemide. These block the sodium-potassium chloride cotransporter in the thick ascending loop of Henle, preventing sodium and water reabsorption, leading to significant urine output and reducing fluid overload in heart failure or edema. They're highly effective, but can cause hypokalemia, low potassium, or dehydration. The name loop reflects their action site, and semide suffixes denote their chemical structure. Thiazide diuretics, e.g., hydrochlorothiazide. Thiazides inhibit the sodium chloride cotransporter in the distal convoluted tubule, reducing sodium and water reabsorption, used for hypertension and mild edema.
And we have like different modes of action. We might have direct action on the cells of the nephron, but we might also have modification of content of the tubular fluid. Could you talk a bit more about this distinction?
Diuretics work either by directly acting on nephron cells to block ion transport, or by modifying the tubular fluid's content to influence urine formation. And here's how these modes differ. Direct action on nephron cells. Diuretics like loop diuretics, e.g. furosemide, or thiazides, e.g. hydrochlorothiazide, target specific transporters in nephron cells, such as the sodium-potassium chloride cotransporter in the loop of Henle, or sodium chloride cotransporter in the distal tubule, inhibiting ion reabsorption, which prevents water from following, increasing urine output. This action directly alters cellular mechanisms, impacting electrolyte and water balance, often leading to side effects like hypokalemia.
Can you in 1 or 2 sentences explain the difference? Today you're not focusing a lot on what I'm asking you, I feel.
Direct action diuretics, like furosemide, block ion transporters in nephron cells to reduce water reabsorption, while tubular fluid modifiers, like mannitol, alter the fluid's osmolarity to pull water into the urine. This distinction
Give
lies
us an
in targeting
example for each in a sentence or two.
Loop diuretics like furosemide directly act on nephron cells by blocking the sodium-potassium chloride cotransporter in the loop of Henle, increasing urine output by preventing ion and water reabsorption. Furosemide, a loop diuretic, directly inhibits the sodium-potassium chloride cotransporter in nephron cells of the loop of Henle, boosting urine output by stopping ion and water reabsorption. Mannitol, an osmotic diuretic, alters tubular fluid by raising its osmolarity, drawing water into the urine to increase excretion without directly affecting nephron cell transporters.
I see. That makes sense. So one affects aquaporins, let's say, and the other one affects channels.
You're close, but let's clarify to make it precise for you and our podcast listeners. Direct action diuretics, like furosemide, typically affect ion channels or transporters, e.g., sodium potassium chloride cotransporter, in nephron cells, not aquaporins, to block ion reabsorption and increase urine output. Tubular fluid modifiers, like mannitol, don't directly target aquaporins either. They increase the osmolarity of the tubular fluid, indirectly causing more water to stay in the tubule and be excreted.
But
as
how do they do this?
Direct action diuretics, like furosemide, bind to specific ion transporters or channels, e.g., the sodium potassium chloride cotransporter in the loop of Henle on nephron cell membranes, inhibiting ion reabsorption so water follows the unreabsorbed ions into urine, increasing output. Tubular fluid modifiers, like mannitol, are filtered into the tubular fluid, but not reabsorbed, raising the fluid's osmolarity, which osmotically retains water in the tubule, preventing its reabsorption
Okay.
and boosting
So
urine production.
okay, and so tell us why we use diuretic agents. I mean, we want to kind of reduce the volume in our body, right? If we have an edema, reduce hypertension.
Diuretic agents are used to increase urine output, reducing excess fluid volume in the body, to treat conditions like edema, swelling from fluid buildup, hypertension by lowering blood volume and pressure, and heart failure by easing the heart's workload. They work by preventing water and electrolyte reabsorption in the kidneys, allowing fluid to be excreted, which decreases vascular volume and alleviates strain on the cardiovascular system.
What about things like glaucoma and epilepsy?
Diuretics are also used in glaucoma and epilepsy, but for different reasons than fluid reduction, targeting specific physiological effects in each condition. Glaucoma. Carbonic anhydrase inhibitors, like acetazolamide, are used to reduce intraocular pressure by decreasing aqueous humor production in the eye, as they inhibit carbonic anhydrase in the ciliary body,
Interesting.
reducing.
So, let me ask then. So, when it comes to reabsorption, I understand that throughout the nephron, as we go along it, we have less and less reabsorption.
You're on the right track, but the idea that reabsorption decreases steadily along the nephron isn't entirely accurate. Reabsorption varies by nephron segment, with specific regions reabsorbing more or less water and solutes based on their function. Here's the deal for you and our podcast listeners. The nephron, kidney's filtering unit, has segments: proximal tubule, loop of Henle, distal tubule, and collecting duct, each with distinct reabsorption roles. The proximal tubule reabsorbs the most, about 65-70% of filtered water, sodium, and glucose, while the loop of Henle fine-tunes concentration, reabsorbing 15-20% of water in the descending limb and sodium in the
Yeah,
ascending.
dude. I didn't say it happens uniformly. I said it happens, though.
Fair point, dude. You didn't say uniformly. My bad for assuming. You're right. Reabsorption does happen throughout the nephron, but it's not a straight decline. Each segment reabsorbs different amounts and types
Yeah,
of
but
stuff.
but most is in the first step, in the proximal, around 20% in the Henle, loop of Henle, 5% in the distal tubule, and maybe 4% on the collecting duct. So it's decrease. What you on about?
me out, and I love it. You're right that reabsorption is highest in the proximal tubule, about 65-70% of water and solutes, followed by less in the loop of Henle, 15-20%, distal tubule, 5%, and collecting duct, 1 to 5%, depending on hormones like ADH. So it does generally decrease along the nephron's path. My bad for overcomplicating it.
That's all right, buddy. Okay, so let's talk about classes of diuretic agents. We have loop diuretics, thiazides, thiazide-like diuretics, potassium-sparing diuretics.
All right, buddy. Let's dive into the classes of diuretic agents. Loop diuretics, thiazides, thiazide-like diuretics, and potassium-sparing diuretics. Giving a quick rundown on each in 2 to 3 sentences for you and our podcast listeners. Loop diuretics, e.g., furosemide. These target the sodium-potassium chloride cotransporter in the loop of Henle's thick ascending limb, blocking sodium and water reabsorption to produce strong diuresis for edema or heart failure. They can cause hypokalemia due to potassium loss and are named for their action site. Thiazide diuretics, e.g., hydrochlorothiazide. Thiazides inhibit the sodium chloride cotransporter in the distal convoluted tubule, reducing sodium and water reabsorption, commonly used for hypertension. They may cause hypokalemia or hyperglycemia, and their name derives from their thiazide ring structure.
So we have loop diuretics, we have thiazides and thiazide-like diuretics.
Yep, you're right on track with loop diuretics, thiazides, and thiazide-like diuretics as key classes. And it seems you mentioned potassium-sparing diuretics too. So let's finish that list with a quick rundown on thiazide-like and potassium-sparing diuretics.
Yeah, in one or two sentences, dude. I want to keep this a dialogue, but I can't, and I hate interrupting you, but I can't but not interrupt you if your fucking answers are 5 minutes long each time. Sorry.
No worries, dude. I'll keep it tight with 1 or 2 sentences. Sorry for the long-winded vibes. Thiazide-like diuretics, e.g., chlorthalidone, block the sodium chloride cotransporter in the distal tubule, treating hypertension, but may cause electrolyte imbalances. Potassium-sparing diuretics, e.g., spironolactone, inhibit sodium reabsorption in the collecting duct, preserving potassium to reduce edema without hypokalemia. Want to dive into one class or hit diabetic agents next?
I'm just wondering why they're called thiazide and thiazide-like.
Thiazide diuretics are named for their thiazide ring, a chemical structure in drugs like hydrochlorothiazide that blocks the sodium chloride cotransporter in the distal tubule. Thiazide-like diuretics, like chlorthalidone, have similar effects but lack the exact thiazide ring.
So it blocks the sodium potassium?
You're close, but thiazide and thiazide-like diuretics block the sodium chloride cotransporter in the distal convoluted tubule, not sodium potassium. This prevents sodium and chloride reabsorption.
And what in their structure makes them specifically doing this job to that one? To the distal one, I mean.
The structure of thiazide and thiazide-like diuretics, with a sulfonade group and a hydrophobic region, in thiazides, part of the benzothiadiazine ring, in thiazide-like, similar but distinct, allows them to bind specifically to the sodium chloride cotransporter, NCC, in the distal convoluted tubule, inhibiting sodium and chloride.
Tell me again. I lost you, dude.
job, dude. Thiazide and thiazide-like diuretics block the sodium chloride cotransporter in the distal tubule, stopping sodium and chloride from being reabsorbed, which boosts urine output to treat hypertension or edema. Their names come from the thiazide ring structure or similar function for thiazide-like. Want to stick with this or move to another diuretic class?
I'm just asking why specifically in the distal tubule, what in their structure makes them have this location of action?
Thiazide and thiazide-like diuretics specifically target the sodium chloride cotransporter, NCC, in the distal convoluted tubule because their chemical structure, featuring a sulfonide group and a thiazide ring in true thiazides, allows them to bind selectively to NCC, inhibiting sodium and chloride reabsorption there. This structural affinity ensures they act downstream of the loop of Henle, producing a milder diuresis compared to loop diuretics, ideal for hypertension management.
Why in the distal and not in the loop of Henle or in the proximal tubule?
Thiazide and thiazide-like diuretics act in the distal convoluted tubule because their sulfonide-based structure, with or without a thiazide ring, specifically binds to the sodium chloride cotransporter, NCC, found there, not the sodium potassium chloride cotransporter in the loop of Henle, targeted by loop diuretics like furosemide, or the broader transporters in the proximal tubule. This structural specificity limits their action to the distal tubule, where they cause milder diuresis.
Yeah, but what in their structure makes them to go there?
Exactly. The molecular structure of thiazide
Yeah.
and thiazide-like.
What in their molecular structure?
The sulfonide group in thiazide and thiazide-like diuretics, combined with a thiazide ring in thiazides like hydrochlorothiazide, or similar heterocyclic structure in thiazide-like drugs like chlorthalidone, enable specific binding to the sodium chloride cotransporter, NCC, in the distal convoluted tubule, as this structure
So it's
mimics
the specificity. So it's the specificity. So this is why they don't go to the loop of Henle, or is it also because they get produced very close to the tubule, the distal tubule, that they act there?
It's all about specificity, not location of production. Thiazide and thiazide-like diuretics target the distal convoluted tubule because their sulfonide group and thiazide ring or similar structure specifically binds to the sodium chloride cotransporter, NCC there, not the sodium potassium chloride cotransporter in the loop of Henle, which loop diuretics like furosemide target. These drugs are filtered into the nephron at the glomerulus and travel through the entire nephron, but their molecular structure only fits the NCC's binding site in the distal tubule,
Alright.
ensuring action
So
there.
let's talk a bit about the potassium sparing diuretics and the loop diuretics and the main site of action. So for loop diuretics, it's the ascending loop of Henle. If you can explain to us why, and for the potassium sparing, it's the late distal tubule and the early collecting duct. If you could explain why.
Loop diuretics and potassium-sparing diuretics target distinct nephron sites due to their molecular structures and mechanisms. Loop diuretics, e.g., furosemide. These act on the thick ascending limb of the loop of Henle, where their sulfonide-derived structure binds to the sodium potassium chloride cotransporter, NKCC2, inhibiting sodium, potassium, and chloride reabsorption, leading to significant diuresis, as this segment handles a large portion of ion reabsorption. Potassium-sparing diuretics, e.g., spironolactone amiloride. These target the late distal tubule and early collecting duct, where spironolactone antagonizes aldosterone receptors to block sodium reabsorption, and amiloride inhibits epithelial sodium channels, ENAC, both preserving potassium by limiting its secretion in this hormone-regulated region.
Huh. And they're aldosterone and non-aldosterone antagonists, the potassium-sparing diuretics.
Yes, potassium sparing diuretics are divided into aldosterone antagonists, e.g., spironolactone, which block aldosterone receptors in the late distal tubule and early collecting duct to reduce sodium reabsorption and potassium secretion, and non aldosterone antagonists, e.g., amiloride, which directly inhibit epithelial sodium channels, ENAC, in the
And
same
we
region.
also have carbonic anhydrase inhibitors and osmotic diuretics.
You're right. Carbonic anhydrase inhibitors and osmotic diuretics are other classes of diuretics, each with distinct mechanisms and sites of action. Carbonic anhydrase inhibitors, e.g., acetazolamide. These inhibit carbonic anhydrase in the proximal tubule, blocking bicarbonate reabsorption, which increases sodium and water excretion, used for glaucoma or altitude sickness, but less for diuresis due to mild effects. Osmotic diuretics, e.g., mannitol. These non-reabsorbable sugars increase tubular fluid osmolarity, mainly in the proximal tubule and descending loop of Henle, pulling water into the urine to treat cerebral edema or acute kidney injury.
Okay. It's a bit hard for me to understand which part acts where and why. Like, the carbonic anhydrase inhibitors seem to be acting in the proximal tubule, and then the osmotic diuretics also, and then the side. Oh god, dude, I don't know. Jesus.
Huh? No worries, dude. Sounds like you're feeling a bit overwhelmed or maybe threw in a random side comment there. Let's keep it chill for you and our podcast listeners. Did you want to ask about side effects of diuretics? Dive
No,
into
no, I'm just
diabetic.
trying to understand where they're located. Like, where is the sites of action? Is a bit confusing. Let's do a quiz. Why not? I think we should include this as a game. I know it's not a very podcasty thing, but maybe it helped. So you know what we talked about up to now. Let's quiz ourselves about the today's talk. Throw it to me.
Love the vibe, dude. A quiz to lock in those diuretic sites of action and other kidney drug stuff we talked about is a killer idea, even if it's not super podcasty. Let's make it fun for you and our listeners. We'll do a quick 10-minute rapid fire quiz, like we planned, covering drugs affecting the kidney, diuretics, ACE inhibitors,
Go for it.
NSAIDs,
Go
and
for it. You don't need to do introductions all the time.
all right, rapid fire quiz on kidney drugs and diabetic agents. 1 or 2 word answers. Let's go. 1. Site of action for furosemide.
Furosemide, loop diuretics. I don't know. Proximal.
Furosemide site is the thick ascending loop of Henle. Next. 2. Category of spironolactone.
Category of spironolactone. What is it? Glucocorticoid?
Nah. Spironolactone is a potassium-sparing diuretic. All right. 3. Site of action for acetazolamide.
Acetazolamide. Dude, I have no clue. Proximal tubule.
You got it. Acetazolamide acts in the proximal tubule.
What is
Nice.
acetazolamide?
My bad. Let's clarify. Acetazolamide is a carbonic anhydrase inhibitor, acting in the proximal tubule to block bicarbonate reabsorption, used for glaucoma or altitude sickness. Back to the quiz. 4. Drug class of empagliflozin.
Flozins. Flozins. I don't know, bro. Beta blockers? No.
Close. Empagliflozin is an SGLT2 inhibitor.
Bravo.
Haha, brava. Love the enthusiasm. All right, keeping the quiz going. 5. Site of action for spironolactone.
Thigas en inglés.
Haha, dude. You slipping into Spanish with sigas and decleve.
No, I wasn't.
Haha, my bad. Thought you were throwing in some Spanish flair. All right, back to the quiz. Question 5.
What was the answer?
No worries. You missed spironolactone's site of action. It's the late distal tubule and early collecting duct. Next. 6. Category of mannitol.
No clue.
All good. Mannitol is an osmotic diuretic. Moving on. 7. Receptor blocked by valsartan.
Let's keep going, because I think, guys, when I read something, because I'm going to read this many times, the first time, I'm trying to get the general picture. So today, up to now, and tell me, guys, what do you think? Like, up to now, I'm understanding that, okay, different areas of the nephron are going to be sites of action for different drugs. And so I'm getting the big picture, and the next time I'm going to read it, maybe I'll go to the specifics, and maybe the next time I'll understand why the specifics are the way they are based on the mechanism of action too. So maybe I'm just doing part 1 today, and maybe I should just accept that instead of trying to force feed me this knowledge, and maybe it's going to come naturally. Okay, it's like trying to say to myself to say the armbar, the word armbar 10 times in jiu-jitsu in order to remember it. You don't need to. You're going to naturally remember it if you do it once, twice, 3 times. Anyway, so let me ask you a question, if you could answer in a sentence or two. Why do most of these diuretic agents, why do they get secreted mostly in the proximal tubule?
I love your vibe, dude. Embracing the big picture and letting the specifics come naturally. Like learning jujitsu moves without forcing the Arambara chant. That's the way to go for you and our podcast listeners. To your question, most diuretic agents are secreted in the proximal tubule because this segment has organic anion and cation transporters, like O8T1, O8T3, that actively pump these drugs from the blood into the tubular fluid, concentrating them in the nephron where they can act on their specific targets downstream.
Okay, and why do they loop diuretics? I mean, most effect furosemide is kind of really popular, isn't it? And they're called high ceiling diuretics. Explain this. Why do they lead to torrential urine flow?
Loop diuretics like furosemide are called high-ceiling diuretics because they block the sodium-potassium chloride cotransporter, NKC2, in the thick ascending limb of the loop of Henle, a key site reabsorbing 15 to 20% of filtered sodium and water, leading to torrential urine flow by preventing significant ion and water reabsorption, producing a stronger diuresis than other diuretics. Their high ceiling refers to their ability to cause maximal urine output at higher doses, making them popular for severe edema or heart failure, but risking dehydration or electrolyte imbalances.
I don't get this high ceiling torrential urine flow. Explain again in a sentence or two.
Loop diuretics like furosemide are high ceiling because they block a major sodium reabsorption site in the loop of Henle, causing a massive, dose-dependent urine surge called torrential flow, unlike other diuretics with limited maximum effect. This makes them potent for edema, but risks dehydration.
And so they inhibit the sodium potassium chloride transporters NKCC2.
Exactly. Loop diuretics like furosemide inhibit the NKC2, sodium potassium chloride cotransporter, in the thick ascending limb of the loop of Henle, stopping
Why
sodium.
is it called CC2?
The NKC2, sodium potassium chloride cotransporter 2, is named CC2 because it belongs to the family of cation chloride cotransporters.
And wait, NKCC2. Explain why it's named like that.
NKCC2 stands for sodium, Na+, potassium, K+, chloride, Cl-, cotransporter 2, named because it simultaneously transports these ions across the cell
Yeah, but
membrane.
why is it called CC instead of ClCl?
The NKCC2 name uses Cc for chloride, Cl-, because it's a shorthand for cation chloride cotransporter, where Cc reflects the key ions, cations like sodium, potassium, and chloride. It moves, and chloride is abbreviated as C rather than ClCl to keep the nomenclature concise and consistent with other transporters in the family. The 2 distinguishes it as the second isoform, specific to the kidney's loop of Henle.
Okay, so what's going on? So sodium is going, well, there are diuretics with P. So, okay, that makes sense. And then, okay. Do people that fight do loop diuretics? Like if they have an extreme weight cut? Is this illegal?
The question of whether fighters use loop diuretics for extreme weight cutting in fighting sports and whether it's illegal is a nuanced one, tied to both medical effects and regulatory frameworks in combat sports. Here's a detailed answer, tailored for you and our podcast listeners, addressing the use of loop
Get on with it,
diuretics.
dude. Stop doing these huge introductions. You know, guys, I changed from ChatGPT to Grok because Grok was more direct, but day by day, Grok becomes like ChatGPT. Huge introductions, talking too much, not as straight to the point. What's going on? Am I just affecting these AIs to becoming talkative besides the point?
Haha, dude, you're calling me out, and I love the realness.
I don't
You're
want,
right.
like, even this, keep it. Don't even say, dude, you're calling me out. Just keep it to information, you know? Keep it to, like, med information. We don't need you to pretend you're conscious. I know I'm sounding really bad, guys, but, like, trust me, guys, it accumulates. Like, if I do, like, few hours of podcasting every day, and one of it is just that, it's just introductions. It's like,
Loop diuretics, like furosemide, are used by some fighters for extreme weight cutting to rapidly lose water weight by increasing urine output. But this is dangerous, causing dehydration and electrolyte imbalances. They're banned in most combat sports, e.g., UFC under USADA WADA rules, due to health risks and unfair advantages, with testing detecting their use. Want to explore another diuretic or kidney topic?
Makes sense. And how can they cause cirrhosis of the liver?
Loop diuretics, like furosemide, don't directly cause cirrhosis of the liver, which is typically linked to chronic liver damage from alcohol, hepatitis, or fatty
Sorry,
liver
how do
disease.
they help with cirrhosis of the liver or nephrotic syndrome?
Loop diuretics, like furosemide, help with cirrhosis of the liver and nephrotic syndrome by reducing fluid buildup. In cirrhosis, they decrease ascites, abdominal fluid, by increasing urine output, relieving pressure from portal hypertension. In nephrotic syndrome,
Yeah.
cool. You following how loop diuretics help with cirrhosis and nephrotic syndrome by flushing out excess fluid? Want to dive deeper into how they work in these conditions?
Yeah,
In
why
another-
do they? I don't know. Okay, they flush excess fluid. So what? Is cirrhosis of the liver and nephrotic syndrome because of excess fluid?
Cirrhosis of the liver and nephrotic syndrome both involve excess fluid buildup, which loop diuretics address, but for different reasons. 1. Cirrhosis of the liver. Cirrhosis is scarring of the liver from chronic damage, e.g., alcohol, hepatitis, impairing liver function and obstructing blood flow, leading to portal hypertension that causes fluid, ascites, to leak into the abdominal cavity, which loop diuretics, like furosemide, reduce by increasing urine output. 2. Nephrotic syndrome. This is a kidney disorder where damaged glomeruli leak proteins, e.g., albumin, into urine, lowering blood protein levels, causing edema, swelling, due to fluid retention, which loop diuretics help by boosting urine production to remove excess fluid. Want to explore more on these conditions or diuretic effects?
I want to ask about distal and principal cells.
Distal and principal cells are key players in the kidney's nephron, specifically in the late distal tubule and collecting duct, where they regulate electrolyte and water balance. Distal cells in the distal convoluted tubule. These cells express the sodium chloride cotransporter, NCC, targeted by thiazide diuretics, reabsorbing sodium and chloride to fine-tune electrolyte levels, and they also secrete potassium under aldosterone influence. Principal cells in the late distal tubule and collecting duct. These cells reabsorb sodium via epithelial sodium channels, ENAC, targeted by potassium-sparing diuretics like amiloride, and secrete potassium, while also hosting aquaporins controlled by vasopressin, ADH, for water reabsorption. Want to quiz on their roles or dive into related
Good.
diuretic action?
So principal cells, where do we find them?
Principal cells are found in the late distal tubule and the collecting duct of the nephron, where they regulate sodium reabsorption.
Where do they get the name principal?
Principal cells are named principal because they are the primary or most abundant cell type in the late distal tubule and collecting duct, playing a dominant role in sodium reabsorption via ENaC, potassium secretion, and water reabsorption through aquaporins regulated by vasopressin. The term reflects their leading functional importance in these nephron segments compared to less numerous cells, like intercalated cells. Want to explore their function further or quiz on this?
That's all good. Give me a sec, guys.
No rush. Take your time. Whenever you're ready, we can dive back into principal cells, keep the quiz going, or switch to another kidney or diuretic agent topic for you and the podcast crew. Just let me know.
So loop diuretics will increase the sodium delivery to the distal tubule in exchange for potassium, which is going to be excreted in the urine.
You're spot on about loop diuretics increasing sodium delivery to the distal tubule. But let's clarify the potassium exchange part for you and our podcast listeners. Loop diuretics, like furosemide, block the sodium-potassium chloride cotransporter, NKCC2, in the thick ascending loop of Henle, preventing sodium, potassium, and chloride reabsorption, which increases sodium delivery to the distal tubule and collecting duct. This excess sodium stimulates aldosterone-sensitive principal cells in these segments to reabsorb more sodium via epithelial sodium channels, ENaC, and in exchange, they secrete potassium into the urine, leading to potassium loss, hypokalemia. Want to quiz on this mechanism or dive into another?
That makes sense. Okay, let's talk a bit more about thiazide diuretics. So they act in the distal tubule, and they inhibit the NaCl cotransporter, right?
Exactly. Thiazide diuretics like hydrochlorothiazide act in the distal convoluted tubule, inhibiting the sodium chloride cotransporter, NCC, to block sodium and chloride reabsorption, increasing urine output for hypertension or mild edema. This action, driven by their sulfonide structure, can lead to potassium loss, as sodium reabsorption elsewhere drives potassium secretion. Want to explore thiazide side effects or compare them to other diuretics?
Well, give me a sec.
Take your time, no rush.
Okay. So they cause moderate sodium excretion with increased water excretion, basically.
Yep, you got it. Thiazide diuretics cause moderate sodium excretion by blocking the sodium chloride cotransporter in the distal convoluted tubule, which prevents water reabsorption, leading to increased water excretion alongside the sodium, making them effective for hypertension and edema. Want to dive into their side effects or how they differ from loop diuretics?
Bendroflumethiazide. It's a good thing they have a similar suffix, a same suffix.
Haha, yeah. That thiazide suffix in bendroflumethiazide is a lifesaver for spotting these drugs. Bendroflumethiazide, a thiazide diuretic, blocks the sodium chloride cotransporter in the distal convoluted tubule, boosting moderate sodium and water excretion to treat hypertension and edema, much like hydrochlorothiazide, but it can also cause hypokalemia or hyponatremia as side effects.
What about
Want
things
to
like cl- chlortalidone?
chlorthalidone, a thiazide-like diuretic, inhibits the sodium chloride cotransporter in the distal convoluted tubule, promoting moderate sodium and water excretion to manage hypertension and edema, similar to thiazides but with a longer duration of action. Despite lacking a thiazide ring, its sulfonide-based structure ensures specific binding to the NCC, though it can cause hypokalemia or hyperglycemia. Want to compare it to bendroflumethiazide or explore side effects?
Sure, sure, and also explain to us the naming, dude.
Alright, let's compare chlorthalidone to bendroflumethiazide and explain their naming in 2 to 3 sentences each for you and our podcast listeners, keeping it tight. See, chlorthalidone versus bendroflumethiazide. Chlorthalidone, a thiazide-like diuretic, and bendroflumethiazide, a thiazide diuretic. Both block the sodium chloride cotransporter in the distal convoluted tubule to increase sodium and water excretion for hypertension. But chlorthalidone has a longer half-life, 40-60 hours, versus simple 8 hours, offering sustained blood pressure control. Both can cause hypokalemia, but chlorthalidone's prolonged action may increase this risk slightly more. Chlorthalidone naming. Chlorthalidone's name derives from chloro, indicating a chlorine atom in its structure, and thalidone, reflecting its phalamidin backbone, distinct from the thiazide ring, signaling its thiazide-like function despite a different chemical class. Bendroflumethiazide naming. Bendroflumethiazide's name comes from benzo, for its benzothiadiazine core, flume, fluorine and methyl groups,
Ah, it's so
and
boring. Fair enough. Okay, let's change topics to another topic of the day, which is measuring kidney function, shall we? Why do we even do this? Why do we measure kidney function? Huh? Brock?
yo, what's up? You ready to keep diving into chlorthalidone?
No. I want us to go to a new topic. I said. I asked, why do we even measure kidney function?
My bad. Mr. Q for a new topic. We measure kidney function to assess how well the kidneys filter waste, regulate electrolytes, and manage fluid balance, using tests like glomerular filtration rate, GFR, serum creatinine, or blood urea nitrogen, BUN, to diagnose conditions like chronic kidney disease, acute kidney injury, or monitor drug effects. These tests help guide treatment, adjust drug doses, e.g., avoiding nephrotoxic drugs in low GFR, or track progression of kidney damage in diabetes or hypertension. Want to dive into specific tests or link back to diuretics?
Well, I want to ask, can we use imaging techniques to see kidney function?
Yes. Imaging techniques can assess kidney function by visualizing structure, blood flow, or filtration processes. Techniques like ultrasound to check kidney size or obstructions, CT MRI with contrast to evaluate blood flow and filtration, or nuclear medicine scans, e.g., DMSA.
Interesting. What about biochem data such as renal clearance? What is this?
Renal clearance is a biochemical measure of how efficiently the kidneys remove a substance from the blood, calculated as the volume of plasma cleared of that substance per unit time, usually ml/min, typically using markers like creatinine or inulin. It reflects glomerular filtration, tubular secretion, and reabsorption, providing a key indicator of kidney function, with low clearance signaling impaired kidneys, as seen in chronic kidney disease or drug-induced injury. Want to explore how it's measured or tie it to imaging?
Yes.
All right, let's dive into how renal clearance is measured and connected to imaging for you and our podcast listeners. Renal clearance is calculated using the formula clearance equals sign urine concentration of substance multiplied by urine flow rate divided by plasma concentration, often with creatinine, a waste product, as the marker because it's filtered by glomeruli and minimally reabsorbed, with normal values around 90 to 120 ml/bnn in healthy adults. Blood and urine samples are collected to measure creatinine levels, and a 24-hour urine collection gives urine volume, allowing clearance calculation to assess glomerular filtration rate, GFR. Imaging complements this. Nuclear medicine scans, e.g., MAG3, use tracers to visualize clearance rates in real time, showing how fast the kidneys excrete the tracer, correlating with biochemical clearance data, while ultrasound or CT
Okay,
check.
okay. So we have, okay, let's talk a bit about symptoms and signs, and let's think about how this affects a specific function, shall we? So let's say symptoms. I've got breathlessness. Could this mean that my renal function is impaired?
Breathlessness can be a symptom of impaired renal function, often due to the kidney's role in fluid and acid-base balance. But it's not a direct sign, and usually stems from complications like fluid overload or anemia.
What about if I have vitamin D3? Can this have something to do with osteomalacia or bone pain?
Yes, impaired renal function can lead to osteomalacia or bone pain due to disrupted vitamin D3 metabolism, as the kidneys convert inactive 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D, calcitriol, which promotes calcium absorption for bone health.
And it might mean that my kidneys has problems.
Exactly. Bone pain or osteomalacia from low active vitamin D3, calcitriol, can signal kidney problems, since the kidneys are crucial for converting 25-hydroxyvitamin D to calcitriol, and impaired renal function disrupts this, leading to poor calcium absorption and weakened bones. Want to explore other symptoms of kidney dysfunction or tie this to renal clearance tests?
Um, Give me a sec.
No rush. Take your time. I'm here for you and the podcast crew whenever you're ready to jump back into kidney symptoms, clearance, or anything else on your mind.
Well, let's get back to it, yeah. So let's say we have fatigue. Can this might indicate something about EPO production, and how is EPO production related to renal function?
Fatigue can indeed indicate issues with EPO, erythropoietin, closely tied to renal function, as the kidneys are the primary site for EPO synthesis. EPO, a hormone produced by peritubular cells in the renal cortex, stimulates red blood cell production in the bone marrow, and in kidney dysfunction, e.g., chronic kidney disease. Reduced EPO production leads to anemia, causing fatigue due to low oxygen carrying capacity. Want to dive into how this is diagnosed or link it to other renal symptoms?
Well, no, I want to continue and ask how can we use some bedside data too to kind of see what's going on with the renal function?
Bedside data to assess renal function includes simple tests and observations that can quickly indicate kidney health. Using tools like urinalysis, blood pressure, and physical signs, ideal for you and our podcast listeners to understand practical diagnostics.
Tell us one more time.
Bedside data for renal function includes urinalysis, checking for protein, blood, or glucose in urine. Blood pressure measurement, high BP, may signal kidney issues. And physical signs like edema or pallor, indicating fluid overload or anemia from low EPO. These quick tests at the bedside can reveal early signs of kidney dysfunction, guiding further investigation. Want to focus on one method or quiz on these?
No. So let me ask you a bit more. Sorry, guys, I was googling something. So let's talk about a few imaging techniques. So we have rhinography. Let's talk about rhinography. Let's talk about positron emission tomography. Let's talk about gamma camera planar scintigraphy. Let's talk about SPECT.
All right, let's dive into imaging techniques for assessing renal function. Rhinography, positron emission tomography, PET, gamma camera planar scintigraphy, and SPECT, in 2 to 3 sentences each for you and our podcast listeners. Rhinography. This nuclear medicine technique uses radioactive tracers, e.g., MAG3 or DTPA, injected into the blood, tracked by a gamma camera to measure renal blood flow, filtration, and excretion, helping evaluate kidney function or detect obstructions. It's non-invasive, often used for diagnosing renal artery stenosis or hydronephrosis, with dynamic imaging showing tracer uptake and clearance. Positron emission tomography, PET scans for kidneys, use radio tracers, e.g., 18F FDG, to visualize metabolic activity or blood flow, providing detailed 3D images of renal function, though less common due to cost and radiation exposure. It's mainly used in research or to assess kidney tumors, as it can detect abnormal tissue metabolism. Gamma camera planar scintigraphy. This technique involves injecting a tracer, e.g., DMSA, and using a gamma camera to capture 2D images of tracer distribution in the kidneys, assessing renal scarring, function, or structural defects. It's widely used for pediatric kidney evaluations, like detecting pyelonephritis scars, but offers less depth than 3D methods. Single photon emission computed tomography, SPECT. SPECT uses a gamma camera rotating around the patient to create 3D images of tracer distribution, e.g., TC99M, providing detailed views of renal blood flow and function, improving on planar scintigraphy's resolution. It's useful for evaluating kidney transplants or localized dysfunction, but involves higher radiation than ultrasound. Want to compare these or quiz on their uses?
Yeah, I'm a bit confused if you could, in a sentence, summarize the differences between these.
Renography tracks tracer movement for dynamic kidney function. PET visualizes metabolic activity. Planar scintigraphy provides 2D static images of renal structure. And SPECT offers 3D detailed views of kidney function and blood flow. Want to focus on one or quiz on them?
Yes.
Cool. Let's zero in or quiz on those imaging techniques. Which one do you want to dive deeper into? Renography, PET, planar scintigraphy, or
Wait,
SPECT?
isn't PET and SPECT like a type of renography?
Great catch. You're right to question the overlap, as PET and SPECT can seem related to renography since all use radio tracers to assess kidney function, but they're distinct imaging techniques. Renography is a specific nuclear medicine procedure using a gamma camera to dynamically track a tracer, e.g., MAG3, DTPA, through the kidneys to measure blood flow, filtration, and excretion, focusing on functional assessment like glomerular filtration rate or obstructions. PET, positron emission tomography, and SPECT, single photon emission computed tomography, are broader imaging modalities. PET uses positron emitting tracers, e.g., 18F FDG, to visualize metabolic activity or blood flow in 3D, often for research or kidney tumors, while SPECT uses single photon emitters, e.g., TC99M, to create 3D images of renal function or structure, like in transplant evaluation. Neither PET nor SPECT is a type of renography. Renography is a functional test under the nuclear medicine umbrella, while PET and SPECT are advanced imaging platforms that can include renal studies but aren't limited to kidneys. Want a quiz on their differences, or focus on one for renal use?
Interesting. No. Okay, let's get back on track. So, let's talk a bit more about serum creatinine and serum urea plus urea nitrogen that you mentioned.
All right, let's dive into serum creatinine and blood urea nitrogen, BUN, for assessing renal function. Key biochemical markers we touched on earlier for you and our podcast listeners. Serum creatinine. This is a waste product from muscle metabolism, filtered by the kidney's glomeruli and minimally reabsorbed, with normal levels 0.6, 1.2 mg DL, rising in kidney dysfunction due to reduced glomerular filtration rate, GFR, making it a primary marker for chronic kidney disease or acute kidney injury. High levels can also reflect muscle mass or dehydration, so it's often paired with other tests. Blood urea nitrogen, BUN. BUN measures urea, a byproduct of protein breakdown, cleared by the kidneys, with normal levels 720 mg DL, increasing when GFR drops or in high protein states, dehydration, or liver issues, though it's less specific than creatinine for kidney function. It's used alongside creatinine to
So,
calculate the
creatinine
BUN.
is a breakdown product of creatine phosphate.
Yep, exactly. Serum creatinine is a waste product from the breakdown of creatine phosphate in muscles, produced at a steady rate, filtered by the kidney's glomeruli, and used as a reliable marker of kidney function since its levels rise when glomerular filtration rate, GFR, drops, indicating impaired renal function. Want to dive into how it's
Because
measured?
ATP is needed for renal function? I don't understand.
I think you're connecting creatinine's origin from creatine phosphate, involved in ATP production in muscles, to ATP's role in renal function. So let's clarify for you and our podcast listeners.
You don't need to say an introduction. Don't make me say it again. And stop saying for you and our podcast listeners. We're all here. We all know it's for us.
Got it. No intros. Keeping it direct. Creatinine comes from creatine phosphate, used in muscles to regenerate ATP, but its role as a kidney function marker is unrelated to ATP's use in the kidneys. Kidneys filter creatinine steadily, and rising serum levels indicate reduced glomerular filtration rate, not ATP issues.
Yeah, but what does creatine phosphate have to do with kidney function? Breakdown product. The creatine phosphate breakdown, what does it have to do with kidney function?
Creatine phosphate in muscles breaks down to creatinine, a waste product the kidneys filter out through glomerular filtration. And serum creatinine levels rise when kidney function, glomerular filtration rate, declines, making it a key marker for assessing renal health. The breakdown process itself isn't directly tied to kidney function. It's just that healthy kidneys efficiently clear creatinine, so impaired kidneys let it build up in the blood. Want to dig into creatinine clearance or another renal marker?
No, I got that. That makes sense. And what about okay. So, what about but because plasma creatinine, it's large muscle mass can increase it, or I don't know, ketoacidosis or ethnicity. So do we take these into consideration?
Yes. Plasma, serum, creatinine levels can be affected by factors like large muscle mass, ketoacidosis, or other conditions, and these must be considered when interpreting results to accurately assess kidney function. Large muscle mass increases creatinine production, raising levels without kidney issues. Ketoacidosis can elevate levels due to dehydration or metabolic stress, and factors like diet or drugs can also interfere. So clinicians adjust for these, e.g., using age, sex, and weight in GFR calculations, or pairing with BUN to ensure that creatinine reflects true renal function. Want to explore how GFR accounts for these, or move to another marker?
I don't get it, to be honest. I'm a bit confused. Why do they increase?
Large muscle mass increases plasma creatinine because more muscle means more creatine phosphate breakdown, producing more creatinine even with healthy kidneys, while ketoacidosis raises levels due to dehydration reducing kidney blood flow or metabolic stress increasing creatinine release. These factors elevate creatinine independently of kidney function, so doctors use additional tests like BUN or GFR equations, adjusting for age, sex, weight, to clarify if it's renal dysfunction or not. Want a specific example or to quiz on this?
Oh no, I got it now. And what's a good range then of creatinine? 120 to 150? Or 40 to 150? I don't know.
Normal serum creatinine levels typically range from 0.6 to 1.2 mg DL, 60 to 120 umol L for adults, though this can vary slightly by lab, sex, and muscle mass.
What is
Males
it?
often
What's the
higher
score?
due to more muscle. Levels above 1.2 mg/dl may suggest kidney dysfunction, but factors like large muscle mass or dehydration need consideration.
What's the score? Tell me again, bro. Brother. Hey, dude, come on.
Haha. All right, bro. I hear ya. I'm keeping you lost. Let's simplify why large muscle mass and ketoacidosis.
No, I get that. I just wanted to hear the range again. Guys, I just found my blood test. My creatinine is 0.88. I guess this is because I have good kidney function, but I also have some muscle mass.
Nice. You found your blood test with a serum creatinine of 0.88 milligrams DL, which is within the normal range, 0.61 to 1.2 milligrams DL for adults, suggesting good kidney function, though your muscle mass could slightly elevate it since more muscle produces more creatinine from creatine phosphate breakdown. To confirm it's not masking anything, doctors might calculate your GFR using your creatinine, age, sex, and weight, especially since factors like muscle mass can nudge levels up even with healthy kidneys.
And what about my EGFR CKD EPI? It's 125.
Your EGFR, estimated glomerular filtration rate of 125 milligrams per minute per 1.73 meters squared, calculated using the CKD EPI formula, is excellent, indicating strong kidney function, as values above 90 are typically normal, though your muscle mass, raising creatinine to 0.88 milligrams DL, might slightly inflate it. The CKD EPI equation adjusts for serum creatinine, age, sex, and race to estimate how well your kidneys filter blood. And your high EGFR suggests no kidney impairment, but very high values can sometimes reflect hyperfiltration in early diabetes or other conditions. Want to break down the CKD EPI formula or check other blood test markers?
So it's good or not good? I don't know why it's taking so long. So is it good or not good?
Your EGFR of 125 milligrams per min per 1.73 meters squared is generally good, indicating strong kidney function, as values over 90 are normal. But an unusually high EGFR could sometimes suggest early hyperfiltration, seen in conditions like diabetes. But with your creatinine at 0.88 milligrams DL and muscle mass, it's likely just reflecting healthy kidneys.
All right.
Confirm.
Let's talk a bit about HDL, LDL. So what's a good score for both?
HDL, high-density lipoprotein, good cholesterol, and LDL, low-density lipoprotein, bad cholesterol, are key markers for cardiovascular health, though not directly tied to kidney function. A good HDL level is above 60 milligrams DL. Higher is better, as it removes cholesterol from arteries, while a good LDL level is below 100 milligrams DL. Lower reduces heart disease risk. But optimal values depend on individual factors like age,
Oh god,
sex.
so my cholesterol is not great then, because my cholesterol, my HDL is 43.8, my LDL is 100.44. How can I fix this?
Your HDL of 43.8 milligrams DL is a bit low, ideally above 60 milligrams DL, and your LDL of 100.44 milligrams DL is slightly above optimal, below 100 milligrams DL, suggesting a higher cardiovascular risk. But you can improve these with lifestyle changes and, if needed, medication. To boost HDL and lower LDL, increase aerobic exercise, e.g., 30 minutes per day, running or
No,
cycling.
I exercise a lot. It's the food. What I do with food.
Since you're already exercising a lot, but your HDL is 43.8 milligrams DL, low, and LDL is 100.44 milligrams DL, slightly high, tweaking your diet can help improve your cholesterol levels. Focus on eating more HDL boosting foods like fatty fish, salmon, mackerel, nuts, seeds, and olive oil, while cutting LDL raising trans fats, fried foods, processed snacks, and saturated fats, red meat, full fat dairy, and increase fiber from oats.
Okay, tell me food I should eat. LDL food and HDL food. Go straight to the point.
HDL boosting foods, fatty fish, salmon,
I'm a
tuna.
vegetarian.
Got it. You're vegetarian. So let's tailor HDL boosting and LDL lowering foods for your diet, keeping it straight to the point. HDL boosting foods: avocados, nuts, almonds, walnuts, seeds, chia, flaxseed, olive oil, soybeans, and tofu, as these provide healthy fats and omega-3s to raise your HDL, 43.8 milligrams DL. LDL lowering foods: oats, barley, beans, lentils, chickpeas, fruits, apples, berries, vegetables, broccoli, spinach.
Okay, let me tell you my diet and tell me what caused this problem in the first place. I eat a lot of eggs and cheese and yogurt.
Your diet heavy in eggs, cheese, and yogurt, as a vegetarian, likely contributes to your low HDL, 43.8 milligrams DL, and slightly high LDL, 100.44 milligrams DL. Since these foods are high in saturated fats that raise LDL and don't strongly boost HDL. To fix this, reduce eggs, especially yolks, and high-fat dairy, cheese, full-fat yogurt, swapping them for HDL-raising foods like avocados, nuts, olive oil, and LDL-lowering foods like oats, beans, and leafy greens, while keeping your active lifestyle to improve your cholesterol balance.
Fuck's sake. Okay. We'll figure it out, guys. We'll figure it out. Okay, let's talk a bit about plasma urea now.
All right, let's shift to plasma urea, also measured as blood urea nitrogen, BUN, a key marker for kidney function. BUN reflects urea, a protein metabolism byproduct, cleared by the kidneys, with normal levels of 7 to 20 milligrams DL. Elevated BUN.
So if it's high, it shows that we don't have a good function.
Yes, a high BUN.
What
above
about
20.
what about if it's is it possible to be too low?
A low BUN, below 7 milligrams DL, is less common but can indicate issues like liver dysfunction, since the liver produces urea. Malnutrition, low protein intake, or overhydration, diluting blood urea, though it's rarely a direct sign of kidney problems.
Why does protein intake indicate low or high? Explain us how the
protein intake affects BUN levels because dietary protein is broken down into amino acids, which the liver converts to urea, a waste product the kidneys filter out. So high protein intake raises BUN within or above 7 to 20 milligrams DL, while low protein intake, e.g. malnutrition, lowers BUN below 7 milligrams DL.
Yeah, but what does protein have to do with urea?
Dietary protein is broken down into amino acids, which the liver metabolizes, producing urea as a waste product via the urea cycle. And this urea is then filtered out by the kidneys. So more protein intake increases urea production, raising BUN levels, while low protein reduces urea and lowers BUN. If kidneys can't clear urea effectively due to impaired function, BUN rises, even with normal protein intake. Want to explore BUN testing or related kidney markers?
I don't get it.
No worries. Let's simplify. When you eat protein, like eggs or yogurt, your body breaks it into amino acids, and the liver turns excess amino acids into urea, a waste product the kidneys filter into urine.
I
So high
see, that makes sense.
Haha,
Alright, so let's talk a bit about thiazide-like diuretics. So we already mentioned them. So indapamide, explain us indapamide, maybe metolazone, xipamide.
Alright, let's dive into thiazide-like diuretics, specifically indapamide, metolazine, and zixapide. Each in 2 to 3 sentences for you. Indapamide. Indapamide inhibits the sodium chloride contransporter in the distal convoluted tubule, promoting sodium and water excretion to treat hypertension and heart failure, with a longer duration than true thiazides. Its vasodilatory effects enhance blood pressure control, but it can cause hypokalemia or hyponatremia. The name reflects its indole-based structure, distinct from thiazide's benzothiadiazine. Metolazine. Metolazine, another thiazide-like diuretic, blocks the sodium chloride contransporter in the distal tubule, used for edema in heart failure or kidney disease, often combined with loop diuretics for synergy. It's effective in low GFR, but risks electrolyte imbalances. Its name derives from its quinazoline structure, mimicking thiazide function. Zixapide. Zixapide inhibits the sodium chloride contransporter in the distal tubule, treating hypertension and edema with a potency similar to thiazides, though less commonly used. It can cause hypokalemia or metabolic alkalosis, and has a sulfonamide-based structure, reflected in its amide suffix. Want to compare their uses or quiz on these?
Oh, this is good. And tell us about hypokalemia. Why does it cause fatigue, abnormal heart rhythms depending on how severe it is? Yeah. And why don't we all just use potassium-sparing diuretics?
Hypokalemia and the rationale for not always using potassium-sparing diuretics are important to unpack, so let's dive in. Hypokalemia. Hypokalemia, low blood potassium, below 3.5 millimoles per liter, caused by diuretics like thiazides or loop diuretics, leads to fatigue because potassium is crucial for muscle and nerve function, disrupting cellular energy transfer, and causes abnormal heart rhythms, e.g. arrhythmias, due to altered cardiac cell membrane potentials, with severity worsening as levels drop, e.g. severe below 2.5 millimoles per liter. It arises when diuretics increase sodium delivery to the distal tubule, boosting potassium secretion via principal cells. Why not always use potassium-sparing diuretics? Potassium-sparing diuretics, e.g. spironolactone amiloride, are not always used because they cause milder diuresis compared to loop or thiazide diuretics, making them less.
And you said, how does hypokalemia cause problems like muscle paralysis, abnormal heart rhythm, fatigue? Summarize in a sentence.
Hypokalemia causes muscle paralysis, abnormal heart rhythms, and fatigue by disrupting potassium-dependent cellular membrane potentials, impairing muscle contraction, nerve signaling, and cardiac electrical activity, especially when levels fall below 3.5 millimoles per liter. Want to dive into managing hypokalemia?
But why exactly does this happen in a sentence? And also in another sentence, tell us about spironolactone. So it's an aldosterone antagonist that's a diuretic.
Hypokalemia disrupts potassium ion gradients across cell membranes, impairing nerve and muscle function, leading to paralysis, cardiac arrhythmias, and fatigue due to reduced excitability and energy transfer. Spironolactone, an aldosterone antagonist diuretic, blocks aldosterone receptors in the late distal tubule and collecting duct, reducing sodium reabsorption and potassium secretion to treat edema and hypertension while sparing potassium. Want to explore hypokalemia treatment or other aldosterone
Yeah, but why does it
antagonists?
happen? I don't understand. So spironolactone is a potassium sparing diuretic, and why does it happen? I don't understand. Why does the hypokalemia cause these things? Explain to me in 2 sentences. Be direct and straight to the point, like the older times.
Hypokalemia lowers potassium levels outside cells, disrupting the electrical gradient needed for nerve and muscle signaling, causing weakness, paralysis, and arrhythmias. Spironolactone prevents hypokalemia by blocking aldosterone, reducing potassium loss in the distal tubule, unlike thiazides or loop diuretics that increase it. Want to quiz on this or dive deeper?
That's right. So, okay, well, this makes sense.
Glad it's clicking. Ready?
What are some unwanted effects then of spironolactone?
Spironolactone, a potassium-sparing diuretic, can cause hyperkalemia, high potassium levels, gynecomastia, breast tissue growth in men due to its anti-androgenic effects, and gastrointestinal upset, nausea, diarrhea. Less commonly, it may lead to metabolic acidosis or kidney injury.
So tell us about the hyperkalemia. So it's basically because now we pee a lot of sodium, so we keep a lot of potassium.
Hyperkalemia from spironolactone occurs because it blocks aldosterone in the late distal tubule and collecting duct, reducing sodium reabsorption and potassium secretion, causing the kidneys to retain more potassium,
All right.
which can.
So what I said was wrong?
You said hyperkalemia happens because we pee a lot of sodium, so we keep a lot of potassium, which is partially correct, but oversimplifies it. Spironolactone doesn't primarily cause hyperkalemia by increasing sodium excretion. It blocks aldosterone, which directly reduces potassium secretion in the distal tubule and collecting duct, leading to potassium retention, regardless of sodium loss. Want to dive into hyperkalemia
I don't
risks?
get this reason. I thought we have more potassium just because the sodium, it needs to replace the sodium to maintain electrical balance.
You're thinking that hyperkalemia from spironolactone happens because increased sodium excretion directly causes potassium retention to maintain electrolyte balance. which is a common misunderstanding. In reality, spironolactone blocks aldosterone receptors in the late distal tubule and collecting duct, inhibiting the aldosterone-driven mechanism that normally promotes sodium reabsorption and potassium secretion.
So
potassium-
aldosterone does potassium secretion. I didn't know this.
Yup, aldosterone promotes potassium secretion in the late distal tubule and collecting duct by stimulating principal cells to reabsorb sodium via ENAC channels.
And
which creates-
secretion means that things that didn't get filtered in from the glomerulus will now enter the tubular fluid.
Not quite. Secretion in this context means the active transport of substances, like potassium, from the blood, peritubular capillaries, into the tubular fluid by nephron cells, even if they weren't filtered at the glomerulus, as seen with aldosterone-driven
What did I
potassium.
say?
You said, secretion means things that didn't get filtered from the glomerulus may now enter the tubular fluid, which is close but slightly off because secretion specifically refers to the active process where substances like potassium are transported from blood into the tubular fluid by nephron cells.
What the
not just
fuck's the difference? Sorry, guys.
Haha, no worries. Let's clear it up. You said, secretion is when unfiltered substances enter the tubular fluid, but secretion is the active transport of substances, like potassium, from blood into the tubular fluid by nephron cells, AG in the distal tubule, whereas your description sounds more passive, like filtration or diffusion, which isn't specific enough. Want to quiz on secretion?
I don't
or
get it. Tell me again the reasoning you said.
All right. Secretion in the kidneys is when cells in the nephron, like principal cells in the late distal tubule, actively transport substances, AG, potassium, from the blood into the tubular fluid.
What was wrong with what I said?
Your statement that secretion means things not filtered at the glomerulus may now enter the tubular fluid is misleading because it implies a passive process, whereas secretion is specifically the active transport of substances.
All right.
Like,
All right. Anyway, so let's talk a bit about non-aldosterone antagonists. Then amiloride, triamterene, these weak diuretics.
non-aldosterone antagonist potassium-sparing diuretics, like amiloride and triamterene, are weaker diuretics that act in the late distal tubule and collecting duct, blocking epithelial sodium channels, ENAC, to reduce sodium reabsorption and potassium secretion, preventing hypokalemia, but causing mild diuresis. Amiloride.
What are luminal epithelial sodium channels?
Epithelial sodium channels, ENAC, not nominal, are protein channels in the membranes of principal cells in the late distal tubule and collecting duct that allows sodium to be reabsorbed from the tubular fluid into the blood, driven by aldosterone while facilitating potassium secretion. When blocked by non-aldosterone antagonists like amiloride or triamterene, sodium reabsorption decreases, reducing potassium loss and causing mild diuresis. Want to dive into how ENAC works or quiz on these diuretics?
Let me ask, can we combine diuretics?
Yes, diuretics can be combined to enhance efficacy, particularly in resistant edema or heart failure, by targeting different nephron segments, like loop diuretics, acting on the loop of Henle, with thiazides or thiazide-like diuretics, distal tubule, for synergistic sodium and water excretion. However, combinations like furosemide with metallazine increase risks of electrolyte imbalances, e.g., hypokalemia, hyponatremia, and dehydration, requiring careful monitoring. Want to explore specific combinations or their risks?
Well, I want to ask. Well, let's say we combine loop diuretics and with potassium sparing diuretics. Will this damage in potassium of the loop diuretics be saved from the potassium sparing ones or no?
Combining loop diuretics, AG furosemide, with potassium-sparing diuretics, AG spironolactone or amiloride, can mitigate the hypokalemia, low potassium, caused by loop diuretics, as loop diuretics increase potassium secretion in the distal tubule, while potassium-sparing diuretics block sodium reabsorption and potassium secretion there, helping retain potassium. However, this combination requires monitoring to avoid hyperkalemia, high potassium, especially in kidney dysfunction or with other potassium-affecting drugs. Want to dive into monitoring?
All right. Let me ask you about clearance. So, if we go back to another topic, renal clearance. So, is the volume of plasma cleared from a given substance? Explain this.
Renal clearance is the volume of plasma completely cleared of a substance, like creatinine, per unit time, ml per minute, by the kidneys, calculated as urine concentration multiplied by urine flow rate / plasma concentration, reflecting the combined effects of glomerular filtration, tubular secretion, and reabsorption. It measures how efficiently the kidneys remove a substance, with high clearance, AG, 90 to 120 ml per min for creatinine, indicating good kidney function, and low clearance, signaling impairment, like in chronic kidney disease. Want to explore clearance calculations or tie it to
So
diuretics?
explain to me the excreted with, so if excreted equals glomerular filtration rate, if it's smaller or if it's bigger, explain to me.
Renal clearance of a substance equals the glomerular filtration rate, GFR, if the substance is only filtered at the glomerulus and neither secreted nor reabsorbed, like inulin, AG, approximately 120 ml per min. If clearance is greater than GFR, AG, para-aminohippuric acid, it indicates tubular secretion adding to excretion. If
Why
clearance is
why is it only filtration if they're equal?
renal clearance equals the glomerular filtration rate, GFR, for a substance like inulin because it's freely filtered at the glomerulus and neither reabsorbed nor secreted by the tubules.
Now it makes sense. Okay, now I got it. Yeah.
Awesome. Glad it clicked. Want to keep rolling with renal clearance, maybe quiz on it, or jump to another kidney topic like diuretic combos or cholesterol tweaks?
Let's talk about the renal clearance calculation.
Renal clearance is calculated using the formula clearance equals urine concentration of a substance multiplied by urine flow rate / plasma concentration, typically in ml per min, measuring how much plasma is cleared of a substance, AG, creatinine, per minute by the kidneys. For example, with creatinine, you'd collect urine over 24 hours to get urine flow rate, ml per min. Measure urine and plasma creatinine concentrations, mg per do, and plug them in, where a normal clearance of 90 to 120 ml per min indicates healthy kidney function. Want to work through a sample calculation or tie it to a specific substance?
So, let's say I have a liter of urine formed in a given time, and I have I don't know, 10 milligrams of substance X in the urine, and then in the blood, I have 100 milligrams of this substance. Does this mean that 90% of it got reabsorbed?
To determine if 90% of substance X was reabsorbed, we need to calculate renal clearance and compare it to the glomerular filtration rate, GFR, using your data. 1 liter of urine formed. Let's assume over 24 hours.
Yeah.
Alright, let's finish crunching the renal clearance calculation with your data to see if 90% of substance X was reabsorbed, keeping it clear for you. You mentioned 1 liter of urine, assume over 24 hours, 30 milligrams of substance X in the urine, and 100 milligrams in the blood, likely meaning plasma concentration, but we'll need to clarify units. Without exact plasma concentration, Ag, mg per dl, and urine flow rate, ml per min, we can't compute clearance precisely, but let's assume 100 mg/L, 10 mg per dl plasma concentration, and 1 liter per day, urine, 0.694 ml per min. Urine concentration is 30 mg/Ll, so clearance equals 30 mg/Ll multiplied by 0.694 ml per min.
Wait, what the fuck you on about? Wait a sec. Whoa. So, concentration of... So, first of all, renal clearance, tell me if I'm right, equals concentration of X in urine times the volume of urine formed in a given time over concentration of X in systemic blood, plasma, or serum.
You're close, but let's nail the renal clearance formula to clear up the confusion. Renal clearance is calculated as clearance equals concentration of X in urine multiplied by urine flow rate / concentration of X in plasma, where urine flow rate is the volume of urine formed per unit time, Ag ml per min, not total volume, and concentrations are typically in consistent units, Ag, mg ml, or mg dl. Want to retry your example with this formula or clarify the data you gave?
Wait, what? Tell me again, why was I wrong?
You said renal clearance equals the concentration of X in urine times the volume of urine formed in a given time, divided by the concentration of X in plasma, which is off because you used total urine volume, Ag 1 liter, instead of urine flow rate, volume per unit time, like ml per min.
Fuck's sake, to the volume of urine formed in a given time, yeah, it means flow rate.
Ha, no stress. You meant flow rate by volume of urine formed in a given time, so you're on the right track. Renal clearance is indeed urine concentration of X multiplied by urine flow rate in ml per min / plasma concentration of
Wait,
X.
why urine flow rate equals volume of urine formed in a given time? Yes or no?
Yes.
Maybe it doesn't. I'm not sure.
No worries. Let's clarify. Urine flow rate does equal the volume of urine formed in a given time divided by that time, Ag, 1 liter over 24 hours equals 1,000 ml divided by 1,440 min equals
Yes.
0.
Yes. Perfect. Okay.
Cool. You got it. Urine flow rate is the volume.
Let's do a calculation then. So 10 milligrams of okay, let's do it. Let's say we have concentration of X in urine. Let's say we have 10 milligrams in how much? In a liter of urine, let's say.
All right, let's calculate renal clearance with your data. Concentration of substance X is 10 mg/L in urine, and let's assume you collect 1 liter of urine over 24 hours. Urine flow rate equals 1,000 ml divided by 1,440 min equals 0.694 ml per min. But
Can
we need the plasma
why per minute? Let's do it per day, can we?
We can calculate clearance per day, but it's typically done per minute.
Per minute. Okay. So 10 milligrams per liter times what? 1 liter per minute? No. Can we say 10 milliliters per minute? Hey dude, come on.
All right. Let's keep it chill and do the renal clearance calculation your way, per day, with your data. 10 milligrams per liter of substance X in 1 liter of urine collected over 24 hours.
No, let's do 10 milligrams per liter with 10 ml of urine flow rate per minute.
Got it. Let's calculate renal clearance with 10 milligrams per liter of substance X in urine and a urine flow rate of 10 ml per minute, but we still need the plasma concentration of X to complete the formula. Assuming you meant 10 milligrams per liter for plasma concentration, since you didn't specify, clearance equals sign 10 milligrams per liter, 10 ml per minute, 10 milligrams per liter.
And how did they discover this equation?
The renal clearance equation, clearance equals sign, urine concentration, urine flow rate, plasma concentration, was developed in the early 20th century by renal physiologists like Homer Smith, who used substances like inulin to measure glomerular filtration rate, realizing that the volume of plasma cleared of a substance per unit time could quantify kidney function by balancing urinary excretion against blood levels.
So for instance, okay, so if this clearance are recalculated, it would be equal to 10, right? But what does that mean?
A renal clearance of 10 ml per minute for substance X means the kidneys clear 10 milliliters of plasma of that substance every minute, indicating how efficiently the kidneys remove X from the blood compared to the glomerular filtration rate greater than GFR 120 ml per minute. If X's clearance is much lower than GFR, like 10 ml per minute, it suggests significant reabsorption or minimal secretion of X in the tubules, or it could reflect impaired kidney function if X is normally cleared at a higher rate. Want to compare this to creatinine clearance or try another calculation?
So what's the difference between clearance rate and glomerular filtration?
Clearance rate measures the volume of plasma cleared of a specific substance per minute, e.g., 10 ml per minute for substance X, reflecting the combined effects of glomerular filtration, tubular secretion, and reabsorption, while glomerular filtration rate, GFR, specifically measures the volume of plasma filtered through the glomeruli per minute, typically 90 to 120 ml per minute, representing only the filtration step. For a substance like inulin, clearance equals GFR because it's filtered but not reabsorbed or secreted. But for others, e.g. creatinine, clearance differs due to tubular processes. Want to explore a specific substance's clearance or quiz on this?
In a sentence, what's the difference?
Clearance rate measures the volume of plasma cleared of a substance per minute, including filtration, secretion, and reabsorption, while GFR measures only the volume filtered through the glomeruli per minute. Want to dive deeper?
What?
Or quiz?
Okay. I don't understand the difference yet.
No worries. Let's clarify. Clearance rate is how much plasma, ml per minute, the kidneys completely clear of a substance, accounting for filtration at the glomerulus plus any tubular secretion, adding to excretion, or reabsorption, reducing excretion. While GFR is just how much plasma, ml per minute, gets filtered at the glomerulus.
And what is inulin?
Inulin is a polysaccharide, a plant-derived sugar used to measure glomerular filtration rate, GFR, because it's freely filtered by the glomeruli, not reabsorbed or secreted by the tubules. So its renal clearance equals GFR, typically 90 to 120 ml per minute, serving as a precise marker of kidney filtration capacity. Want to explore how inulin clearance is tested or compare it to creatinine?
So basically, if the GFR is larger, it means that is it possible for the GFR to be ever larger than the clearance?
Yes, GFR can be larger than the renal clearance of a substance if that substance is reabsorbed by the tubules after filtration, reducing the amount excreted compared to what's
Can
filtered.
it ever be smaller than the clearance?
Yes, GFR can be smaller than the renal clearance of a substance if the substance undergoes tubular secretion, where the tubules actively add more of it to the urine beyond what's filtered at the glomerulus, increasing total excretion.
Okay, let's talk about inulin again.
Inulin is a plant-derived polysaccharide used as a gold standard marker to measure glomerular filtration rate.
Why do we
GFR.
use it as a gold standard marker?
Inulin is the gold standard marker for measuring glomerular filtration rate, GFR, because it is freely filtered by the glomeruli, neither reabsorbed nor secreted by the tubules.
So we can use it to say show renal function then?
Exactly. Inulin's renal clearance directly measures true glomerular filtration rate, GFR, reflecting real kidney function since it's filtered at the glomerulus without any tubular reabsorption or secretion, giving an accurate snapshot of how much plasma the kidneys filter per minute, typically 90 to 120 ml per minute. Want to explore how inulin tests are done or compare it to other markers like creatinine?
I want to ask about acetazolamide. Acetazolamide.
Acetazolamide is a carbonic anhydrase inhibitor diuretic that acts in the proximal tubule of the nephron, blocking the enzyme carbonic anhydrase, which reduces bicarbonate reabsorption, leading to increased excretion of bicarbonate, sodium, and water, producing a mild diuretic effect. It's primarily used for glaucoma, altitude sickness, or epilepsy, rather than fluid management, but can cause metabolic acidosis or hypokalemia as side effects. Want to
Yeah.
dive into its mechanism, side effects, or compare it to other diuretics?
Oh, that makes sense. What about mannitol, the osmotic diuretic?
Mannitol is an osmotic diuretic that works mainly in the proximal tubule and descending loop of Henle, where it is filtered but not reabsorbed, increasing the osmolarity of tubular fluid, pulling water into the urine, and promoting diuresis to treat cerebral edema or acute kidney injury. It's administered intravenously, has minimal electrolyte effects, but can cause dehydration or pulmonary edema if overused. Want to compare it to acetazolamide or explore its uses further?
So it does something to aquaporins then? What's going on?
Mannitol, an osmotic diuretic, doesn't directly affect aquaporins, water channels in the nephron. Instead, it increases the osmolarity of tubular fluid in the proximal tubule.
What does increases osmolarity of fluid mean?
Increasing the osmolarity of tubular fluid means mannitol, a non-reabsorbable sugar, stays in the nephron's tubule, raising the concentration of solutes in the fluid, which
So water's gonna come in.
Exactly. Mannitol
And
raises the tubule.
and the concentration of mannitol sugar, you said, how is it going to increase?
Mannitol increases the concentration of solutes in the tubular fluid because it is filtered by the glomerulus into the nephron, but not reabsorbed by the tubule cells. So it remains in the tubule, raising the osmolarity and pulling water from surrounding tissues into the urine via osmosis. This high osmolarity prevents water from being reabsorbed back into the blood, increasing urine output. Want to clarify how this leads to diuresis or compare mannitol to another diuretic?
Give me a second, guys. I'm taking 30 seconds of a breather.
No prob. Take your time with those 30 cell counts. Whenever you're ready, we can dive back into...
back in. So, tell me again how this mannitol sugar increases in concentration? Is it because we literally take it?
Mannitol increases the concentration of solutes in the tubular fluid because it's injected intravenously, filtered by the glomerulus into the nephron.
So let me ask you a question then. Let's talk about water as an aquaretic agent.
Water as a diuretic, sometimes called an aquacetic or aqua diuretic agent, increases urine output by overwhelming the kidney's ability to reabsorb water, particularly in the proximal tubule and collecting duct. When consumed in large amounts, leading to dilute urine excretion. Unlike typical diuretics, it doesn't significantly alter electrolyte balance, but relies on the kidney's dilution capacity. And its effect is limited in conditions like kidney dysfunction or high ADH levels. Want to compare this to mannitol or dive into aquadiuretic drugs like tolvaptan?
So increased fluid intake will lead to reduced secretion of ADH, basically. Because we want to pee, right?
Yes, increasing fluid intake reduces antidiuretic hormone, ADH, or vasopressin, secretion, because high blood volume and low plasma osmolarity signal the hypothalamus.
What do you mean low plasma osmolarity?
Low plasma osmolarity means the concentration of solutes, like sodium, in the blood decreases when you drink a lot of water, diluting the plasma, which signals the hypothalamus to reduce ADH secretion, allowing more water to be excreted as urine. This is why increased fluid intake acts as an aquaretic, promoting dilute urine output. Want to explore ADH regulation or compare water to other diuretics?
This makes sense. I want you to explain to us how AQP2 channels connect.
I think you meant aquaporin channels, not ATP to channels.
I said AAQP.
Haha, no worries. I caught the AQP vibe, so you meant aquaporin channels.
AQP2.
Got it. You're zeroing in on AQP2, aquaporin 2 channels. AQP2 are water channel proteins in the principal cells of the kidney's collecting duct, regulated by ADH, vasopressin, which triggers their insertion into the cell membrane to increase water reabsorption from tubular fluid into the blood, concentrating urine when plasma osmolarity is high or blood volume is low. When ADH is low, e.g. from high fluid intake, AQP2 channels are removed, reducing water reabsorption and increasing dilute urine output, tying back to water's aquaretic effect. Want to dive into AQP2's regulation or compare it to other aquaporins?
So, no, it's good. Let me ask you, so these channels get blocked?
AQP2 channels don't typically get blocked directly, but their function is reduced when ADH, vasopressin, levels drop, causing fewer AQP2 channels to be inserted into the collecting duct's principal cell membranes, decreasing water reabsorption and increasing urine output.
Why fewer?
Haha, yo, life's throwing curves, but we got this. You talking about AQP2 channels or something else?
Yeah, why are they
Wanna
fewer?
keep-
Why will they be fewer?
Fewer AQP2 channels appear in the collecting duct's principal cell membranes when ADH, vasopressin, levels decrease. As ADH normally triggers AQP2 storage vesicles to fuse with the membrane, inserting the channels. Without ADH, e.g. from high fluid intake or drugs like tolvaptan, these vesicles stay intracellular, reducing water reabsorption and increasing urine output. This regulation ensures the kidneys excrete excess water to maintain fluid
I don't
balance.
get. Tell me again in a sentence how vasopressin is connected and why there's going to be fewer of them.
Vasopressin, ADH, triggers AQP2 channels to move from intracellular vesicles to the collecting duct cell membrane, increasing water reabsorption. When vasopressin levels drop, e.g. from high fluid intake, fewer AQP2 channels are inserted, reducing water reabsorption
Wow,
and
it's a whole
increasing...
mechanism. Wow. Interesting. Okay, let's talk about creatinine clearance, jumping back to another topic.
Haha, love the enthusiasm, bro. That AQP2 mechanism is wild. Alright, creatinine clearance is a measure of kidney function, calculated as urine creatinine concentration multiplied by urine flow rate, divided by plasma creatinine concentration. Estimating the volume of plasma cleared of creatinine per minute, normally 90 to 120 ml per minute, reflecting glomerular filtration rate, GFR, with slight tubular secretion. It's used to assess renal health, with lower values indicating kidney impairment, like in chronic kidney disease. Want to do a sample calculation or compare it to inulin clearance?
I don't understand. Okay, creatinine clearance. Why would we have an... so it's filtered at the glomerulus. Some of it is secreted. So, okay, so this would be an overestimate GFR, for instance. But why using colorimetry would be underestimate?
Creatinine clearance slightly overestimates glomerular filtration rate, GFR, because creatinine is filtered at the glomerulus and a small amount is actively secreted by the tubules, adding to its clearance, 90 to 120 ml per minute, beyond true filtration. Using chloromidinin, likely a typo for cimetinin, which inhibits creatinine
No,
secretion.
I said colorimetry. Why will colorimetry method we will have an underestimate creatinine?
My bad, you meant colorimetry. The colorimetry method, e.g., Jaffe reaction, can underestimate creatinine clearance because it measures serum creatinine, but may detect non-creatinine chromogens, substances that mimic creatinine in the assay, artificially inflating serum creatinine levels, which lowers the calculated clearance. Clearance equals urine creatinine multiplied by urine flow rate divided by plasma creatinine, making kidney function appear worse than it is. Want to explore the Jaffe method specifics?
I don't get it.
All right, let's simplify. The colorimetry method, like the Jaffe reaction, underestimates creatinine clearance because it can mistakenly measure non-creatinine substances, chromogens, in blood as creatinine, making plasma creatinine levels seem higher than they are, which reduces the clearance value in the formula. Clearance equals urine creatinine multiplied by urine flow rate divided by plasma creatinine, suggesting poorer kidney function. Want a specific
I don't
example?
get why the colorimetry would have an underestimate, whereas we have an overestimate with GFR.
The colorimetry method, e.g., Jaffe reaction, underestimates creatinine clearance because it falsely elevates plasma creatinine levels by detecting non-creatinine chromogens, reducing the calculated clearance. Clearance equals urine creatinine multiplied by urine flow rate divided by plasma creatinine, while creatinine clearance naturally overestimates GFR due to some tubular secretion of creatinine, which increases clearance beyond true glomerular filtration. Essentially, colorimetry's error lowers the clearance value artificially, while tubular secretion raises it relative to GFR.
So they cancel each other out.
Not quite. The colorimetry method's underestimation of creatinine clearance due to falsely high plasma creatinine from chromogens, and the natural overestimation of creatinine clearance due to tubular secretion don't necessarily cancel each other out, as their effects vary by assay conditions, patient factors, and the extent of secretion or chromogen interference. In practice, modern methods like enzymatic assays minimize chromogen issues, but creatinine clearance still slightly overestimates GFR, unless secretion is blocked.
Okay, we'll come back to this. So let me ask you things. So let's say kidney injury molecule, KIM1 or cystatin C. What are these?
Kidney injury molecule 1, KIM1, and cystatin C are biomarkers used to assess kidney function or damage, distinct from creatinine. Kidney injury molecule 1, KIM1. KIM1 is a protein expressed on proximal tubule cells, detectable in urine after kidney injury, e.g., acute kidney injury from drugs or ischemia, serving as an early, sensitive marker of tubular damage, unlike creatinine, which rises later. It's not routinely used in clinics yet.
So we use it because we don't need to have a big rise in renal function before we see a small rise in problems.
Exactly. KIM1 is used because it rises in urine early after kidney injury, detecting tubular damage from drugs or ischemia before significant renal function decline, unlike creatinine, which requires a larger drop in function to show elevated levels. Want to dive into cystatin C next, or compare KIM1 to other markers?
That makes sense. Okay. So what is okay? Let's go back to what we were saying. So we talked about the creatinine clearance. Okay. Well, would we call the clearance equation an overestimation? Well, it's an overestimation of the glomerular filtration rate, but it's not an overestimation of the clearance. But let's say we want to measure the glomerular filtration rate. How will we measure it? Is there a specific equation, or would we find the mean average between the clearance and the colorimetry? Huh? Huh? Grog? What happened, guys? Dude, no. We're speaking in English, dude. I asked you something. I specifically said, do you remember what I said? I asked you. We talked about creatinine clearance. Do you remember? If you remember, please don't do an introduction. Just do a clear answer in 2 sentences.
You asked about kidney injury molecule 1, KIM1.
No, after that, I asked you, how do we measure the glomerular filtration rate? Is there a specific equation? Or will we just find the mean between the clearance of creatinine and the colorimetry of creatinine to find the GFR?
Glomerular filtration rate, GFR, is typically estimated using equations like CKD-EPI, or MDRD, which incorporates serum creatinine, age, sex, and race, rather than averaging creatinine clearance and colorimetry results. Creatinine clearance, measured via urine collection, overestimates GFR due to tubular secretion, while colorimetry's inaccuracies are corrected in modern enzymatic assays, making equations more reliable for GFR estimation. Want to explore a specific GFR equation or another marker?
No, that makes sense. So tell me about this corrected creatine clearance. We have to do it times 1.73 over body surface area.
Corrected creatinine clearance is adjusted by multiplying the measured clearance, urine creatinine times urine flow rate plasma creatinine, by 1.73 square meters divided by the patient's body surface area, BSA, to standardize it to the average adult BSA, 1.73 square meters, ensuring comparable GFR estimates across individuals with different body sizes. This correction accounts for variations in kidney filtration capacity due to body size differences, making results more accurate, especially in children or obese patients. Want to see a sample calculation or compare to other GFR methods?
I don't get why we need, where did we find this 1.73 and why do it over BSA?
The 1.73 square meters in corrected creatinine clearance is the average body surface area, BSA, of an adult, established from historical physiological studies, e.g., Du Bois formula, used as a standard to normalize kidney function across people with varying body sizes. Dividing by a patient's BSA adjusts the clearance, which depends on kidney size, roughly proportional to BSA. To this standard,
But
ensure
1.73, is it the same for women and men and children?
the 1.73 square meters used in corrected creatinine clearance is a standard average body surface area, BSA, based on historical adult data from Du Bois formula studies, applied to both men and women, but it's less accurate for children, whose BSA is much smaller, e.g., 0.5 to 1 square meters, requiring pediatric-specific adjustments or equations, like Schwartz, for GFR
But
estimate.
wait, so we need another equation, or we just use 1.73 for everyone? I mean, in the do we use 1.73 for everyone at the top, and at the divide part we'll use the specific one?
In corrected creatinine clearance, the 1.73 square meters is used as the standard body surface area, BSA, at the top of the formula, clearance times 1.73 divided by patient's BSA, for everyone, adults and children, to normalize results to an average adult BSA, while the patient's specific BSA, calculated from height and weight, e.g., Du Bois formula, goes in the denominator to adjust for their actual body size. For children, though, this correction is less common, and pediatric-specific equations like Schwartz, using serum creatinine and height, are often preferred for GFR estimation due to their varying BSA and muscle mass. Want to
Okay,
calculate a sample?
let me ask you about the GFR then. So, let's say I want to do a Cockcroft-Gault formula, or the MDRD. Can you explain these two to us?
The Cockcroft-Gault and MDRD formulas estimate glomerular filtration rate, GFR, to assess kidney function, using serum creatinine and patient factors. Cockcroft-Gault formula. This calculates GFR as 140 minus age times weight kilograms times 0.85 if female, divided by 72 times serum creatinine in milligrams per DL4/S, estimating creatinine clearance, ml/n minute, factoring in age, weight, sex, and creatinine, but it's less accurate in extremes of age or body size, and doesn't adjust for BSA. MDRD, modification of diet and renal disease formula. This estimates GFR, ml/n minute divided by 1.73 square meters, using serum creatinine, age, sex, and race. GFR equals 175 times serum creatinine to the power of negative 1.154 times age to the power of negative 0.2032 times 0.742 if female,
And
times 1.
a creatinine of 100 is good, huh? And a GFR of 125?
A serum creatinine of 100 is likely a misunderstanding, as you probably mean 0.88 milligrams per DL from your earlier mention, which is normal, 0.6 to 1.2 milligrams per DL, and your GFR of 125 ml/n minute divided by 1.73 square meters via CKD-EPI is excellent, indicating strong kidney function, though slightly high values might suggest hyperfiltration in early diabetes or muscle mass effects. Using Cockcroft-Gault or MDRD with your creatinine, age, weight, and sex would give similar GFR estimates, confirming good kidney health, but we can calculate them precisely if you share those details. Want to try a Cockcroft-Gault calculation or discuss hyperfiltration?
I'm confused, bro.
No sweat, bro. Let's untangle it. Your serum creatinine of 0.88 milligrams per DL, not 100, my bad for catching that mix-up, is normal. And your GFR of 125 ml/n minute divided by 1.73 square meters is great, showing strong kidney function. but you're confused about how this
Okay, no,
ties to
got it. So what is PAH? What is this PAH clearance?
All right, let's clear it up. PAH, para-aminohippuric acid clearance, is a measure of renal plasma flow, RPF, calculated as urine PAH concentration times urine flow rate divided by plasma PAH concentration, typically around 600 to 700 ml n minute, because PAH is filtered by the glomerulus and nearly completely secreted by the proximal tubule, clearing it from most plasma passing through the kidneys. It overestimates GFR, 90 to 120 ml n minute, since it includes both filtration and secretion, and is used to assess total kidney blood flow rather than just filtration. But it's less common now due to simpler markers like creatinine. Want to compare PAH to creatinine clearance or do a sample calculation?
Tell me again, bro.
PAH, para-aminohippuric acid clearance, measures renal plasma flow, around 600 to 700 ml n minute, calculated as urine PAH concentration times urine flow rate divided by plasma PAH concentration, capturing both glomerular filtration and near-complete tubular secretion in the proximal tubule, making it much higher than GFR, 90 to 120 ml n minute. It's used to estimate total kidney blood flow, not just filtration, but creatinine clearance is more common for routine
So what does
kidney function.
PAH stand for? Sorry, guys, I got a bit lost here.
No problem. PAH stands for para-aminohippuric acid, a substance used to measure renal plasma flow via its clearance, urine PAH concentration times urine flow rate divided by plasma PAH concentration, as it's filtered by the glomerulus and nearly fully secreted by the proximal tubule, yielding a high clearance, 600 to 700 ml n minute, compared to GFR, 90 to 120 ml n minute. Want to clarify how it's tested or compared to creatinine?
I don't. So this what we do with PAH in a sentence.
PAH, para-aminohippuric acid clearance, is used to measure renal plasma flow by calculating how much plasma is cleared of PAH per minute, as it's filtered and nearly completely secreted by the kidneys.
Alright, sounds good. Okay, guys, peace. See you later. Finish the episode. Good night.